Okay. Good evening, everybody. Welcome back to another. It's Wednesday again, and welcome back to another session of webinar. Today we have Dr. Cheah, who's a consultant physician and rheumatologist at Sunway Medical Center. So this CPD point will be awarded by Sunway Medical Center, and we will do something that is interactive today. We're going to do spot diagnosis. So what we'll do is, as Dr. Cheah shows the picture, we would like you to key in what is the diagnosis on the chat group, on the chat, yeah? So let's invite Dr. Cheah. Cheah, go ahead.
Okay, so thanks everyone for being here. Thank you for inviting me to this platform.
Your sound is a bit like robotic. Is it robotic? No? Yeah, I find it a bit robotic.
I can hear it very clearly.
Okay, fine. Go on.
Okay. So right. So I'm going to I've created some scenarios with all these images and pictures so that we can have an more interactive sessions. Again, this is about spot diagnosis in rheumatology. It's basically what you see from first glance, and then please share with me what is in your mind after you see the first every picture or scenarios. Yeah. So I'll start off with question number 1. So again, I'm going to start off with.
Sorry, Cheah, you hold on for a while. I made a mistake. I went to share on the Facebook live on my page. Sorry, I need to share it in I've told everybody to go beating hearts. Okay. I've got it now. Sorry. Yeah.
Okay.
Nobody will be watching. Sorry.
So shall we continue?
Yeah, we can continue.
Okay. So again, this is spot diagnosis in rheumatology. I've created quite a number of questions with pictures and images. Then as you see the pictures with a first glance, then please share with us or share with me what is in your mind, and then we can discuss further. So so the first picture will start off with pictures of a pair of hands of a 40-year-old lady. So this is with a history of 3 months of multiple joint pain over the both hands with a morning stiffness of more than 30 minutes. So I think this will not be difficult. So a pair of hands. So can anyone share with me what is in your mind and what can you see and what is the possible diagnosis?
Okay, so the diagnosis is people are faster than you can speak, okay?
So where can I see the
okay, so you look at the bottom there, okay? And you can see that there is a chat at the bottom. Do you see? Okay, so you see the chat and you can see everybody replying to you. And Balwan Singh has put up the hand. Okay, Balwan, what do you want to ask? You put up, you raise your hand.
Okay, that's great.
Is there anything you want to ask? Okay, so
of course the first question is the first picture is rheumatoid arthritis, but I would like to know who can actually describe what they can see from this image.
So now, okay, this is very important, this description, and it's because Dr. Cheah is also an examiner, so you better know him and be friends with him. He's an examiner for PACER, right? PACER. And Sunway Medical Center is the first, I think, first private medical center to actually be a center for examination for MRCP. So we all consultants are encouraged to look for cases for you guys, whoever takes the exam. And I think that description is very important.
Yeah.
So if you can, give us some description, you know, what joints are involved, maybe what do you see and things like that. Yeah. Okay, anyone? Okay.
No dactylitis. No, there's no evidence of dactylitis there, and of course there's no Bouchard's there. So I mean, Bouchard's means presence of nodal other osteoarthritis, so this is not the case. Yes, symmetrical PIP joint swelling, yes. And you can also see some of the areas of PIP, the skin overlying it, there seems to be some area of hyperpigmentation. So why is that so? Because these are the so-called, these changes happens after the so-called post-inflammatory hyperpigmentation changes. So yes, proximal PIP joint swelling, no DIP involvement. So of course the diagnosis is very clear cut. This is rheumatoid arthritis. Yeah. Okay, let's go to the next one. Okay, so this X-ray shows typical changes of rheumatoid arthritis of the hands. So as you can see, because it's an inflammatory process, so there will be every prominence of a so-called metacarpal. Okay, so symmetrical polyarticular involving MCs and PIP joints. So that is a hallmark of rheumatoid arthritis. So the onset of both hands onset is normally happening more than 90% all the time. But of course, we do see patients who did present to us with a first presentation of not over the hands, but over the knees, ankles, and so on, right? So when there's evidence of hyper-inflammatory changes over the joint, so there will be some reactive changes, and then ended up that patient will end up with periarticular osteopenia. So these are the things that you can see here. And again, this is the disease of synovial. So when there's a chronic synovitis, they will lead to erosion. So you can see there will be a marked erosion over the carpal joint, radial carpal and radial ulnar carpal joints. Yeah, and of course the MCPs and the PIP joint. The distal joint is actually preserved. So remember, rheumatoid arthritis do not affect distal interphalangeal joint. If there's evidence of PIP joint involvement, then you have to think twice before you mark it down as a rheumatoid arthritis. So this is very simple.
Can I ask why? Why so?
This is how it is. We do not know why there is a predilection. I mean, same thing goes to other form of arthritis. So there's it's always that the pattern is a certain type of arthritis will affect certain joints. And rheumatoid arthritis is definitely DIP joint so-called exclusion. No involvement of DIP joint.
Oh,
okay, so so now we know it's rheumatoid arthritis. So this patient has come with this type of hands for 3 months and with this type of X-ray. So anyone want to actually just voice it out? What will be the treatment modality for this patient? Anyone?
Okay, good. Anyone? How will you treat the patient? Anyone? This is very important for GPs, yeah.
Okay.
Salon.
Yes. And steroids. Yes. So what else? This will be the first line treatment because you would like to actually control the inflammation as soon as possible. Okay, remember the principle of inflammatory arthritis is to control the inflammation. What the patient perceives as inflammation is pain, but when they feel that there's no pain, they think that there's no inflammation. So it's not necessarily the way. So anti-inflammatory good dose is important, yes. So, but remember, this is just as a bridging therapy. Do not treat the patient with long-term anti-inflammatory without putting the patient on DMARDs, disease-modifying anti-rheumatic drugs. Yes, ideally you should refer to rheumatologist for further assessment. Yes, DMARDs would be the words. And then among the DMARDs, methotrexate, yes, correct, Nikita. So will be the first conventional synthetic DMARDs that we use because it's still the most cost-effective. If patient plan for pregnancy, next option is sulfasalazine. Yeah, good. Sulfasalazine is safe for pregnancy. So it will be the choice for those patients who are actually in the childbearing age of planning to have family. Because methotrexate, you have to stop the methotrexate for at least 3 months. Other medications such as leflunomide is totally out if let's say it's a childbearing age lady planning to get pregnant. Yes, biologic. Yes, Serena. Biologic is a good thing, but so for those patients who are not responding to conventional synthetic DMARDs such as methotrexate, sulfasalazine, and so on for 3 months, and they still have moderate to high disease activity, then you should consider escalating to biologic therapy. biologic therapy such as anti-TNF, IL-6 inhibitor, even the small molecules such as Cheah inhibitor. So these are the so-called advanced therapy, which has actually made a lot of changes in terms of the treatment outcome in RA. So do you know what is the main issue here? It's a cost, because biologic therapy is not cheap, it's very expensive. Hydroxychloroquine is part of the so-called DMARDs, conventional synthetic DMARDs, but unfortunately it's a very weak DMARDs that we do not use as a first-line therapy. Instead, I will normally use as an adjunct therapy add-on together with methotrexate. Why? Because hydroxychloroquine added on to methotrexate will give that kind of synergistic effect, with the kind of effect of 1 + 1 more than 2. It increases the so-called potency of the methotrexate without needing to increase the dose of methotrexate. But by itself, hydroxychloroquine is not really a strong DMARD. Should we add folic acid? Yes. If let's say patient require this on methotrexate, you should actually supplement with folic acid the day after in order to minimize the side effect of methotrexate. Good.
Is it folic acid for methotrexate or is it for hydroxychloroquine?
No, it's usually meant for those patients who needs methotrexate therapy. Other than that, sulfasalazine, hydroxychloroquine, you need not to actually add on folic acid supplementation. But remember, do not add on folic acid together with methotrexate, as you render methotrexate ineffective.
Oh, interesting.
When we stop, does it affect the response? Okay, when we start after, when we stop. Okay. Okay, so the principle of taking COVID vaccine while patient is on methotrexate is that if let's say the patient needs to take the so-called COVID vaccine, stop the methotrexate dose the week after. Because what happened is that methotrexate seems to be able to actually dampen the effect of the body reaction towards the vaccine, thus making it ineffective.
Oh, I see. I never knew that. Okay, cool. Very interesting.
Okay. So we move on to the next question. Okay, so another pair of hands, but this time around belongs to a 50-year-old snail. Okay, so again, chronic joint pain over both hands for 5 years and stiffness with deformities. So at a glance, I know it's a bit blur, but can you see something which is very abnormal there?
Oh, I know the diagnosis. Okay, I think I know the diagnosis. Okay, anyone?
This is not RA lah. In first case is RA, second case is definitely not RA.
Yeah. Of course.
Exclude one possibility. Anyone?
Okay, I know. Anyone? How come this one nobody knows? Okay.
Yeah.
So, yeah.
Okay, good. Psoriatic, no, not gout. Psoriatic arthritis.
No,
Yes, correct. So what can you see from the hands there? Anyone can describe?
Okay, let's do the description again. Anyone can description, okay?
Yeah. Not only pitting here, this is already new dystrophy. So not just pitting. Yeah, DIP joint involvement, correct? Yeah. So this will be typical of psoriatic arthritis. So comparatively, psoriatic arthritis, the so-called pattern of joint distribution varies. Okay, so they can have few different patterns. Yeah. So number one will be the DIP joint involvement, the distal interphalangeal joint. So that will be very simple. Number two will be the symmetrical polyarticular RA-like pattern. That makes your life a bit difficult because it mimics the RA distribution. Number three is asymmetrical oligoarthritis. So it's just one joint here, but not symmetrical the other side, right? Number four will be the kind of big joint arthritis, such as involvement of the knee or ankle. And then the last one is actually you cannot be seen in the regular X-ray unless you look for it, which is the axial involvement. Why axial involvement? Because psoriatic arthritis actually belongs to the family group of HLA-B27 associated spondyloarthropathy. So among them, they may have actually a kind of overlapping features. Thus, you do have patients with a peripheral joint pain because of psoriatic arthritis, but at the same time having inflammatory back pain because of the axial joint involvement. So let's look at this X-ray. So this X-ray again is a different picture altogether. So instead of MCP or DIP joint involvement, so this patient's hands X-ray showed more of a distal interphalangeal joint involvement. And if you look at the distal interphalangeal joint, the severe distal interphalangeal joint involvement will lead to the kind of terminal exhaustion, giving rise to the kind of typical pencil cup deformity. Okay, so comparatively, rheumatoid arthritis and psoriatic arthritis, erosion is not much seen in the initial phase because psoriatic arthritis is the disease of enthesial as compared to rheumatoid arthritis, which is a disease of synovial. So what happens is that when there's enthesial inflammation, they will lead to so-called osteoproliferation, so-called the bony growth over the so-called periarticular rather than erosion. Okay. In terms of treatment-wise, what comes first? The arthritis or skin problem? Okay, good question. Most of the patients will have a kind of skin psoriasis preceding the so-called onset of arthritis, and the average actually can reach up to 10, 15, or even 20 years later. But certain type of skin psoriasis will actually predispose to higher risk of psoriatic arthritis involvement. Number one will be the nail psoriasis. Number two will be the scalp psoriasis. So the so-called area of skin involvement, the so-called whether it's large or small doesn't matter. Okay, so so if let's say the patient has a scalp psoriasis or nail psoriasis, you need to be more watchful in terms of the development of psoriatic arthritis in the future. Okay, so what will be the other extra articular features that you can think of? Anyone?
Anyone?
Apart from joints, any other so-called psoriatic arthritis features that you can actually look for when the patient comes to you with all these joint condition?
No? Anyone?
Have you heard of enthesitis? Dactylitis? No?
No.
Axial involvement? Yes. Uveitis? Yes, correct. Like I mentioned just now, because it's part and parcel of HLA-B27 associated disease, so the patient may have non-infectious uveitis, so acute red eye, or axial involvement that can mimic the kind of so-called axial spondyloarthritis of Axon. Okay.
Can you
bowel inflammation? Yes. Inflammatory bowel disease, correct? Yeah.
What is axial involvement again? Please educate me.
Axial involvement means involvement of the spine. Something like
okay.
So they may have that kind of inflammatory back pain, particularly over the sacroiliac joint, that gives rise to the kind of inflammatory back pain feature, pain late at night, wake them up in the second part of the night, and then very advanced, very prominent morning stiffness in the morning. Yeah.
Who can also get bowel involvement?
Yes, IBD, inflammatory bowel disease. So that's why psoriatic range of patients, they do have to see different specialty. If let's say they have a different area involvement. For example, I do have patients who I co-manage with the eyes because of uveitis, as well as a gastro because of IBD. Because it will actually involve so-called decision making on what treatment to give that can cover both things. Okay, osteoporosis is not exclusive to psoriatic arthritis. In fact, it can happen in any form of inflammatory arthritis in long run. Yeah. So as mentioned just now, I mentioned about enthesitis. Go and read about it. These are the area of enthesial inflammation. Enthesial is a part where the tendon is attached to the bone. So the commonest place that you look for will be the Achilles tendon at the back of your heel, as well as the epicondyle of the femur, as well as the elbow. So always feel for the tender point there. Another thing is called dactylitis. You will not miss it. The whole fingers or the toes swollen like sausage, as described as a sausage digit. So these are the hallmark of all these psoriatic arthritis feature. Okay, treatment-wise, okay, as compared to rheumatoid arthritis, any other, okay, so what can be the so-called treatment that it can be used to treat psoriatic arthritis? Anyone? Do you use steroid for psoriatic arthritis? Anyone? MTX, yeah. Do you use oral steroid for psoriatic arthritis? Yes, correct. Steroid will worsen the skin, particularly if the patient has underneath or overlying skin psoriasis as well. So do not use systemic steroid on a patient with psoriatic arthritis. in the patient with a so-called acute joint pain with effusion, sometimes in the desperate measure, we do give intra-articular steroid injection, but not oral steroid, yeah? Because when you off the oral steroid, you may actually cause the skin psoriasis become worsened, and then you may end up with erythrodermic psoriasis later. Okay, so treatment-wise, yes, methotrexate plays a role as it can actually control both psoriasis and the psoriatic arthritis. Okay, number 2 is sulfasalazine, but sulfasalazine doesn't help with the skin psoriasis. Hydroxychloroquine doesn't work, yeah, doesn't work. And then yes, biologic. And as compared to so-called rheumatoid arthritis, the biologics in psoriasis will be Cellcept. No, we don't use Cellcept for psoriatic arthritis. Yeah, I mean Cellcept is mycophenolate mofetil. Biologic, we have anti-TNF, we have so-called IL-17 inhibitor, and then we also have JAK inhibitor. Right? Arava, leflunomide, yes, it can be used, but actually the effect is actually not very convincing and it's not that cheap. So usually my personal take is that I will not go to Arava or leflunomide.
Can I ask you, if you treat the skin, does the arthritis get better?
No, you should say that when the aim of treatment is actually to target two birds with one stone. So the effective treatment should be the one that can cover all the domains as much as possible. So like for example, if you use methotrexate, it covers the skin as a joint, but sulfasalazine doesn't cover the skin. And if you use biologics will cover the domains, but some biologics will have a better domain control on skin, some better on the joint, some better on the eyes, and so on. So that's why, yes, azathioprine we do use, but rarely, because it's not really good for the joint. It may be helpful for the skin. Another one is cyclosporine. It doesn't help with the skin joint, but it can be used among the dermatologists. Cycloquinumab, yes, that is the IL-17, which is in the market now. Another one is the ixekizumab. So these are the two IL-17 which are very effective.
Okay, it's obvious that the viewers are very knowledgeable.
Yeah,
I have to admit that I'm not so knowledgeable. Can you explain what is biologic to us?
Biologics as a term, these are the so-called genetic engineered protein molecule that actually has a very specific so-called predilection of targeting the specific inflammatory molecule that is involved in the disease, in that particular inflammatory disease. So that's why it's actually targeting on the particular molecule. For example, that's why you have the tumor necrosis factor inhibitor, you have the interleukin-6 inhibitor, you have interleukin-17 inhibitor, you have interleukin.
Okay, so biologic is a very loose term for all this. So the biologic for rheumatoid arthritis could be different from the biologic from for psoriatic.
Yes, correct. There are some which can use for both. For example, anti-TNF inhibitor can cover both. But IL-6 can be used for RA, but not in psoriatic arthritis. IL-17 works in psoriatic arthritis and so on, but not in RA, because they work at a different inflammatory pathway.
And these biologic, are they injectable or they are oral?
Biologics are normally injectable. They come in the form of infusion, or they have that kind of subcutaneous auto-pen injector. Comes in the form of 2 weekly, monthly injectable. Yeah. As another one that actually I didn't mention just now is actually JAK inhibitor, Janus kinase inhibitor. So this will be the advanced therapy because it's an oral small molecule. It actually goes into the cellular pathway and then acts at the molecule level. So that one is oral therapy.
And how long is this kind of treatment? Forever?
Okay, I'm not going to use the word forever. I'm going to use the word long term. Remember, these are the chronic inflammatory disease, rheumatic disease. So there's no so-called the word cure. The principle is to bring the disease to remission, treat to target, bring down the disease to remission so that the patient does not experience inflammation, pain, structural damage, and so-called can improve their quality of life. So when they are in remission, we'll try to keep it to as long as possible. By definition, sustained remission means keep them in remission for at least 2 years. Then try to taper off the whatever medication that they are on. Some patients who are lucky enough, they can be tapered off the medication, waiting for it to come back again. some, unfortunately, they will need to be on some basal therapy in long run.
Okay, so this when we talk about biologic, let's say for rheumatoid arthritis, how much are we looking at for a year kind of treatment?
It's cheaper than your cardio intervention.
Okay.
Okay, average we are talking about advanced therapy. We are talking about average of around 2,000 to 3,000 per month.
Okay.
Yeah, but of course, because of more and more companies are coming out with their newer agent, so there's always a price competition. So it makes the market even more interesting now. Yeah, they have their patient support program and so on.
For example, a GP who has now cannot handle the patient with rheumatoid arthritis now wants to refer, he must at least know, okay, why don't this is how much it will cost, you see. That's very important. Okay, go on. Okay,
so there's one question, should we do HLA-B27 test? In case of psoriatic arthritis, because it's a very clear-cut diagnosis, I don't think we should waste the money to go and do the HLA-B27, because HLA-B27, I think at the moment it costs around 400-500 ringgit if I'm not wrong. Another point to take note is that HLA-B27 positivity differs, the rate of positivity differs from disease to disease. For example, in the case of ink spot, it can be as high as 90%. But in cases of psoriatic arthritis or psoriasis, it's actually around 30 to 40%. So if it's negative, it doesn't mean anything. If it's positive, well, it just proves that you are right. So it's only useful if, let's say, you are suspecting, for example, certain disease whereby you think this patient may have back pain, but you don't know, you don't really cannot really make out what sort of back pain you are looking at, and then you don't have access to the MRI. So HLA-B27 may be one of the cheaper option or another alternative to actually come up with better diagnosis. Are biologics covered by insurance? That's a tricky part. If let's say those patients requires intravenous infusion, they need to be admitted to daycare or even wards, yes, they are covered by the medical insurance, but otherwise, as an outpatient, unfortunately, they are still not covered. Okay, let's move on to the third one. Okay, so again, this will be the psoriasis distribution. So remember to look hard for any when you have patients who presented with that kind of a joint condition, and the patient never actually tell you about any history of so-called skin disease. So please look hard for all this distribution of a psoriatic patch. You'll be surprised that actually the small little patch actually is hidden somewhere. Okay, so behind the ear, at the umbilical area, even at the so-called ear fold. So these are the areas that I always normally flip through when I want to look for all this psoriatic patch. Yeah. Okay, now we go to another scenario. Again, then this is another pair of hands. It's a 70-year-old lady. Again, come to you with a chronic bilateral joint pain and swelling. So this one, I think, is a no-brainer. Anyone?
Oh, I think I know. Okay. I seem to know a lot of rheumatology.
Good.
Okay.
Good. Someone already spelled it out. Osteoarthritis. So this will be the osteoarthritis of the hand or nodal osteoarthritis of the hand. So as you can see, the swellings are all bony swelling, and then it involves the PIP and DIP joint. So there are typical names for that. So those who are, the Bouchard's node over the PIP joint, and then the Herbert's node over the DIP joint. As you can see, it almost never involves the MCP joint. So that's the main difference between osteoarthritis and rheumatoid arthritis. Yes, primary OA hands, yes, it's acceptable. So what will you look for if, let's say, patient has this pair of hands that show you? What other things that you look for? What joints, what other joints you look at? Anyone? Knee, yes. When you have a patient with osteoarthritis of the hand, almost every is going to be associated with bilateral osteoarthritis of the knee. Okay. Interestingly, also you can also look at their daughters. Okay, because osteoarthritis of the hands has some form, has some degree of so-called inheritance among the ladies. So if let's say the mother has these OA hands, the daughter may have that kind of hands in the future as well. Range of movement, yes, you are right, but do you think range of movement will be affected in OA hands? Normally not, okay, because they are not destructive in nature, so it normally doesn't actually affect the hip range of movement much, except for some so-called discomfort when moving the so-called particular joint because of the friction. So typical features of osteoarthritis hand, these are the symmetrical, again, distal interphalangeal joint, right? So characterized by the joint space narrowing, osteophyte, okay, the bony overgrowth that gives rise to the kind of bony swelling, bone remodeling, and as mentioned just now, the turbulence and sharp spokes. Okay, so what will be your advice or treatment for this patient? So the patient asks you whether I have some. I always get this question every time. Do I have rheumatism, or do I have do I need any treatment? So what is your N6 analgesic? Okay, yeah. So pain control, PCM, yes. I think yeah. So basically, it's about patient education. They need to understand that this is something that can't avoid. It's a part and parcel of degenerative changes. As I normally like to joke with my patient. It's just like our car spare parts. As time goes by, they undergo wear and tear. It's just that these are the joints that which are not replaceable. Okay. Right. So I think the advice is very important for them in order to slow down the progression as well as reduce the symptom. So always advise them, try to advise them to minimize the usage of the small hand joints. For example, the housewife would like to twist and turn the cloth, or using the small little scissors to pinch or to actually cut the bonsai or whatsoever. These are the activities that probably you should ask them to avoid as much as possible. Instead, using the ergonomic ways to reduce the so-called pressure in the small joints. Another thing is pace out their activities. Don't ask them that they have a housework from 8 to 5, but make sure, try to advise them to actually space out every hour, maybe rest for 5 to 10 minutes to allow their joints to recover. Okay. Vitral as gastrinine, these are the supranuclear, or okay, these are the ones that actually be mentioned to be able to help to reduce the cartilage inflammation and help to regenerate the cartilage to a certain extent. But if you want to actually scrutinize these agents strictly based on their studies, all these vitral gastrinine, they do not help with hands osteoarthritis, but they do help with knee plus minus a bit of hip osteoarthritis. So if let's say your target is on the knee, yes, you can give a try on glucosamine sulfate, gastrinine, yeah, for up to 3 months and see their response, but not with the hand osteoarthritis. Intra-articular steroids, no, I do not recommend deep injection of intra-articular steroids in those small little joints. I know someone did that, but I don't think it's advisable, because it will actually cause further degenerative changes over the affected joint. And again, you have to understand that this is something which is not reversible. If you jab, then after they don't take care of the joint, they get inflamed again, then you are not going to jab again, because it can increase the risk of joint damages and infection. So IA steroid for hand probably is not a good option. For the big joints such as knee, ankle, yes, possible.
Okay, can I ask a question? I mean, all of us age, right?
Yeah.
But why not all of us get osteoarthritis of the hands?
Yeah.
And why not all of us get osteoarthritis of the knees?
Okay.
And sorry, a last question is: is there a predominant to? Is it predominant to certain gender or certain race?
Okay. No. Okay. So osteoarthritis onset is multifactorial. So there is some genetic component there. That's why, especially osteoarthritis of the hand, there seems to have some genetic predilection, whereby if your mother has it, the daughter may have it as well. Slightly higher so-called risk of developing in the future. In terms of race-wise, not really. In terms of gender-wise, actually, if you look at the worldwide data, it's actually equal. So then the factors that come into play is your activities involve the previous trauma, the injuries, and so on affecting the joint. So why you get osteoarthritis of the knee if the person is always actually use their so-called feet to work. I mean, for example, those hard work laborer, even the footballer, so the sportsman who always get sports-related injury, so that will predispose them to get early osteoarthritis later. For those who get hand osteoarthritis, those who need to do a lot of manual work with their hands, for example, the housewife, the cook, even the teachers, when you use a lot of paperwork or typing, yeah. So these are the so-called ongoing process that will actually accelerate the process of degeneration. So multifactorial here. Age of onset, again, it depends on individual. For ladies, the osteoarthritis onset will be accelerated when they're reaching menopause age because of the loss of estrogen protective effect. For male, not really related to that, but again, it's more towards the kind of aging as time goes by. Okay, for the knee, your weight plays an important role. If let's say the person is overweight, of course, it will actually cause a lot of so-called weight related damages to the knee. So then we get the early osteoarthritis as compared to the others. The supplements like omega-3 or calcium. Okay, omega-3 or calcium do not prevent OA. Omega-3 fish oil, omega-3 supplements is one of the natural anti-inflammatory that can be used as a adjunct for those people who do not fancy or you want to minimize the usage of NSAIDs, because they do have some natural anti-inflammatory property at a dose of 1,500 mg a day, but as an adjunct. Calcium, no, it does not help to prevent osteoarthritis. Lifestyle, yes, correct. Okay. So I think we move on, yeah?
Yeah, we move on.
Yeah. Okay, again, this is another question. 45 years old with a chronic joint pain and swelling. Again, this is no-brainer. So anyone can just shut up, please.
Oh, I think I know.
You can come and run my clinic.
I don't know how to treat. I may be able. Yes.
Yeah. Gouty arthritis is tophi.
Yes,
Excellent. So as you can see, the big little lump there is tophi. Yeah. So tophi, gouty arthritis. So now the next question is: if the patient show you this hand, so what else will you look for? What else will you do in terms of examination?
Anyone? Okay, while we wait for the question, answers, I mean, okay, we have done only 4 hands, 4 pair of hands.
Yeah.
And we already done 40 minutes. I definitely need to
okay, so I have to speed up that.
Bring you back again.
Okay, so this is chronic tophaceous gout, yeah. So what you can see in the X-ray is that the swelling is actually made out of tophi. So the tophis are all these uric acid deposits, uric acid crystals, and then become crystallized and become a stone. And it has the potential to actually encroach into the joint, erode the bone, and give rise to the kind of a typical punch-up lesion. Because under the normal chest radiograph, plain radiograph, the osteophyte, the tophi is actually radiolucent. You can see a bit of a whitish there. Sometimes when they have a secondary calcification, they can see some calcified area there. So this will be the tophi. So when you have a chronic tophaceous gout, it shows that the gout is very poorly controlled. You allow the uric acid to go up the sky high for years and years until it develops that way. Because if you remember, the natural history of gout is that it's always started with one attack, then after that recurrent attack, then after that chronic, and then start to develop tophi. Yeah. So bites the kidney. Good. Link the joint by the kidney. Very good one. So you affect the joints. So the tophi can be found around around the joint. Okay. Even at the soft tissue such as at the pinna and the so-called the ankle, the Achilles tendon. Yeah. So these are the area. And then if you also should look for any evidence of a urate calculi by ultrasound KB, look for any evidence of a stone in the kidney. And another thing to point out is that gout is not just a disease by itself, it's a part and parcel of metabolic syndrome. So if you have a patient diagnosed with gout, please look out for other things such as high blood pressure, diabetes, dyslipidemia, fatty liver, because all these trends will come together one after another. So I will tell the patient, gout will not kill you, but the eventual, all these cardiovascular related event, cardiometabolic related event may kill you if you do not control all these things. So treatment-wise, lifestyle and diet advice, aim for the uric acid reduction, start the uric lowering therapy, okay, aiming of, what is the aim of uric acid reduction here? Anyone? What is the magic number? Treat to target. No? Yeah, okay. 360 will be the first target to prevent further gouty arthritis, so-called the so-called thing. But in order to actually allow the gout profile to dissolve, you have to bring down the uric acid to below 300. Yes, correct, 300. Majority of these patients are not adhering to take it. Okay, yeah, I mean, but I think you have to involve a lot of so-called counseling and discussion, and then explanation on the importance of the so-called disease control. I mean, fortunately, majority of my patients who come to me, they do actually, adhere to the treatment. Of course, there will be some lapse day, but then eventually they are able to bring down the uric acid target. So I just need to see them maybe once every 6 months or once a year, just to make sure that everything is controlled and paid. All right.
I find it very surprising. People are more adherent to, let's say, treating the gout than the cholesterol, actually.
I agree, because I think, I don't know why, I realized that there seems to have some so-called stigmatization against the statin.
That's right. I don't know that statin has actually had a lot of publicity or bad publicity, but not gout treatment. The other thing I want to ask is, what is the incidence or prevalence of Stevens-Johnson with Xyloric?
Okay, it's actually not high. It's actually very, very low. It's around 0.0, if I'm not wrong, it's 0.01 to 0.05%. Okay, but again, there's some genetic predilection here. So who are the people who are at risk? Those who are the descendant of Han Chinese, Thai, Korean, and Japs. So you notice that in the West, Stevens-Johnson of alloprenol hardly happens, hardly mentioned at all, but it's always among the so-called Asian population, among the East Asian. So what I will tell my patient is that Stevens-Johnson doesn't happen overnight. So if you want to start your alloprenol with the patient, you have to actually explain to them. So when you take the alloprenol, if you notice that there's any unexplained itchiness on your skin, and if let's say you still continue taking the alloprenol, it starts to get red and scaly, and then progress to oral ulcers and red eyes, then you know that something is not right. So I do have patients who encounter this, but all of them know when to stop and come to me, and then we just need to stop it and then take a bit of antihistamine for a few days, or some steroids for a few days, then they will be good. So touch wood, none of them develop Stevens-Johnson. I think it's about the communication of the patient which plays an important point here. Yeah, because after all, alloprenol is still the most cost-effective treatment. If you don't talk about the original Xyloric, there are wide range of generic alloprenol outside, which is much cheaper than.
Of course. But I've seen about maybe 3 Stevens-Johnson in my life, and all were caused by alloprenol, and you know, it's kind of once you see a Stevens-Johnson, you will never forget it in your career. So is there an association with losartan as an antihypertensive for patient with gout?
Yeah, losartan, good question. Losartan at a dose of 15 milligram does have some mild uricosuric effect. So that's why when I treat my patient who has concomitant high blood pressure, I do use losartan if needed. And another medication which is very useful is amlodipine at 10 milligram. So this combination do have some additional uricosuric effect. Same thing goes to Lipentil, the so-called pinofibrate. They do have some mild uricosuric effect as well. Do you prefer Fiboric or Xyloric? Okay, honestly speaking, I still stick to my old alloprenol, because allopurinol is still the most cost-effective and has a wide range of doses to play around. I know outside they tend to keep at 300, but you know that allopurinol can go up to 900 milligram a day. But of course, please don't do that without consulting the rheumatologist. Some of my patients will go up to 600 milligram a day of allopurinol, and then they are doing well. Colchicine together with Zaloric, yes. For those patients like this who has a so-called chronic tophaceous gout, because when you start the the uric lowering therapy, they will suffer from the kind of frequent flare-ups. Okay, so this is another point that you need to explain to your patient. When you start your uric lowering therapy, because there's a sudden drop in your uric acid, there will be a reversal of this uric acid from the joints into the bloodstream. That in return will also inflict the inflammation that's causing the flare-ups. So the principle of starting medication is that do not hit hard with a high dose, because you don't want the uric acid to drop too quickly. Go slow and then slowly so that the patient can tolerate. So some patients will actually develop that kind of flare-up. So I do give colchicine prophylaxis of 0.6 milligram daily for up to 6 months. But watch out for side effects such as diarrhea. What is the higher dose allopurinol in chronic renal failure? Okay, chronic renal failure or end-stage renal failure, there's no higher dose. You just need to tolerate, gradually increase the dose in order to minimize the side effect occurrence. Because like what I said, it can go up to 900 milligram, but you need to actually go slowly in order to see whether or not we reduce the so-called potential so-called side effect.
Okay, wait, hold on. Can I ask you whether the effect, is it losartan or is it with any ARB?
No, it's only on losartan.
Oh, I see, okay.
Okay, for patient on gout treatment, you realize patient LFT is slightly deranged. No, if the LFT is slightly deranged, you have to look at the cause of the deranged LFT. Is it related to the medication, or is it because maybe patient has concomitant fatty liver disease? So I will not actually stop the medication unless I'm really sure that it's actually directly caused by the medication. We move on.
Okay, we move on because yeah.
So this will be the joint predilection in hand arthritis, as you can see the one in blue. So rheumatoid arthritis, remember, so it's always the MCP joints and DIP joint, and they always pair the DIP joint. Psoriatic arthritis, on the other hand, actually would involve the DIP joint. Okay, osteoarthritis, DIP joint is almost always the case, followed by PIP joint. In most of the cases, it's almost never MCP joint. And then the gout, again, it shares a kind of picture like the rheumatoid arthritis, but in gout, it's usually asymmetrical rather than symmetrical. Yeah. What is the best treatment for acute pain in CRI patient? I think you are referring to gout. Good question. So in terms of improving or controlling the acute pain during gout attack in chronic renal failure patient, okay, what are the three options? NSAIDs, colchicine, or steroid. So NSAIDs definitely is not a choice here if let's say patient has established chronic renal failure. So you are left with colchicine and or steroid. Colchicine, you need to watch out on the side effect because low clearance will lead to so-called diarrhea, colchicine toxicity. So in the patient with CKD stage 3 and below, I would not use more than 0.6 milligram BD or even 0.6 milligram OD for those stage 4 because the cause of diarrhea is very high. Yes, steroid will be actually the least of the evil among the three, even though you may not like steroid, especially if the patient has diabetes, but a short course of steroid actually is considered much a safer option for this patient.
And what's the dose like?
Okay, the dosage like in order to reduce the acute joint pain. Okay, so how I deliver steroid for acute gout is number one depends on whether or not it's polyarticular or monoarticular. If it's monoarticular, if it's injectable, I will offer whether or not they want to actually give a local direct intra-articular injection of steroids to the particular joint, because the local steroid effect is just concentrated on the joint, then it will minimize the side effect. But in the polyarticular, two options. Number one is intramuscular triamcinolone of 18 milligram, iron Shincott, or you can give oral prednisolone of around 20 to 30 milligram and then taper down by 5 milligram every day within a week. So within 1 week, you can just stop the steroid therapy. So with this short course of steroid, you shouldn't lead to any so-called unwanted side effect. Yeah.
Okay. Now, do you have a lot more slides?
I have a lot. Maybe we'll start off with the last one because I didn't expect it to be so like this. Maybe
Yeah.
we'll go for one more.
Yeah, I will definitely go for one more session with you. The only problem is my Wednesday session is full until July. So,
so do business. Never mind, it's okay.
Not business. This is not business. Okay, but maybe we do not Wednesday lah. We do a follow up on this because this is really interesting. This is very important for diagnosis, making. It's also very important for people taking exams, for medical students, for GPs. It's very important for all fields except cardiologists, maybe. Okay, go on.
Okay, so we go for the last case. So this is a bit tricky. This is a 45 years old lady. Is one of the local patients before in the government hospital. So symptom of chronic cough, shortness of breath, and then she also complained of multiple joint pain and stiffness. So and you notice that there are some pressures over the face. So anyone?
No, I think I can make this diagnosis also.
Really?
I think so.
SLE. Okay, Betty, what do you think?
I also thought of SLE.
No, it's not SLE.
Oh, it's not. Okay,
no,
then
it's not.
Okay, give us a hint.
Now, if you say this is not from the patient, this is from the textbook. So
I see. This one I don't know.
Yeah, so someone has mentioned it. Yeah, this is dermatomyositis. So in fact, this patient has not only dermatomyositis with the so-called skin involvement, but she does have that kind of features of dermatomyositis complicated with interstitial lung disease, namely anti-synthetase syndrome. So if you look at the patient's hand, they will have that kind of coarse hands, which is described as in the textbook as a mechanic hand. Okay, so this is a kind of dermatomyositis which actually has a kind of extra cutaneous feature involving the lung, right? And they tend to have this kind of autoantibody of anti-Jo1 positivity. So their presentations are actually not because of the weakness or pain of the muscle, but it's mainly over the lungs, whereby they start to develop the kind of a chronic dry cough and breathlessness. And people may tend to treat them as infection, TB, heart failure, and so on. But turn out that actually the one that works for them will be steroids. Because during the period of time when the interstitial lung disease is very active, steroid will actually work wonder. But of course, in long run, so what will be the options of treatment for these type of patients? They will need immunosuppressive therapy, okay, in the form of either cyclophosphamide, mofetil, or even azathioprine, or even methotrexate, depending on the so-called decision of the treating patient. And please remember, dermatomyositis, you have to look for underlying malignancy, because it's actually closely related to certain type of malignancy, such as GI malignancy. So this may be part and parcel of paraneoplastic syndrome. Okay, yes, anti-synthetase, excellent. I think the one should go for example.
Sorry, what? Can you say again that?
Anti-synthetase, ANTI. I mean the last person.
Yes, what is that now? Is it a treatment or?
No, anti-synthetase syndrome is the specific name for this condition, whereby they will have it's a part of the so-called dermatomyositis spectrum with an interstitial lung disease involvement. Yeah. So
I've never seen a dermatomyositis, and I've forgotten completely there was a disease as such. And I definitely.
The difference between the rash here with the rash in SLE rash is that the dermatomyositis rash will not spare the nasolabial fold. They will get that kind of rash even over the here. So they will not spare. They will not have any nasolabial fold sparing. But in SLE, mala rash, they tend to have the nasolabial fold sparing effect.
I see.
And they tend to be worse than the so-called mala rash in SLE, the features. And on the hands, you can see this is the typical feature of a condition called Guthrie's papules. So always look at the patient's hand when you try to work out on all these diagnoses.
What's the prognosis in this disease?
It depends. Disease like this, if you treat early, you can actually prevent the so-called irreversible damage to our internal structures, such as lung particularly, because most of the patient, if let's say they don't get adequate treatment, they will succumb because of respiratory failure. Because all these interstitial lung disease will eventually lead to so-called failure of the so-called lung function. So if let's say they are treated adequately, of course their lifespan is still shorter than normal population, unfortunately, because of all the long-term complications.
Okay, I think it's going to be 10 o'clock. I mean, we can go on forever. We have not even touched on SLE or anything else.
Actually, it was at the back, but well, yeah.
Yeah, I think we need you to be back. But okay, now we take questions, okay?
Sure.
On whatever that we have discussed, and then we will definitely okay, if anyone shows enough hands up, we will put a special session for Dr. Cheah. So yes, so any questions at all? I think it was excellent. I also really enjoyed it. Okay, so everybody, if I would, because I already planned so many, but I really think that I would give you a very special session, maybe 2 sessions also. Because, you know, rheumatology is a lot on spot diagnosis, I think lah. Just like unlike cardiology, okay. So I really find it really interesting, this one. So if there's no questions at all.
Maybe because it's doing all the documents, sorry.
But it's been very, very nice. It's been very interesting. You need to unshare your slides because now they are more interested in one thing.
Oh, sure.
My how do you call it? My spot diagnosis of QR code. Hold on, I share my QR code first. Okay. So basically, the QR code is for the nurses, the doctors. Can you see the QR code? Can you guys see the QR code? No, not yet. Hold on. I'm sharing already. Okay, hold on. Okay, share. Can you all see the QR code? Also no. Okay, slideshow. Okay, can see already? Okay, this QR code is for doctors. Okay, later I will share the QR code for nurses, but nurses have to register to get the e-cert because doctors is through MMA where you scan and you will get 1 CPD point. And if you can't scan the QR code, you then send me your name, okay, your MMC number and your IC number and your email, okay, in one message to my phone. We will do it manually for you. Okay. So there are some more questions, right? Somebody, no questions at all? Okay, how much is a myositis panel? Somebody asked.
Myositis panel is source sent to labs. You take around 1 to come back, and if I'm not wrong, it costs around 500.
So I can't hear you, sorry.
So it costs around 500 ringgit. We also outsource it to UMMC. So it will take around 1 month to get the results. So if I'm not wrong, they charge us around 500 ringgit for the panel.
Okay, this is the QR code to register for the e-cert for the nurses. So I'll stop recording now. Stop recording. Okay. I will stop recording. I saw